Good morning, everyone. We have immense pleasure to welcome you all on today's national webinar on cervical cancer, organized by Sree Anjaneya College of Nursing, Department of Obstetrics and Gynecological Nursing. Sree Anjaneya College of Nursing, functioning under Sree Anjaneya Medical Trust, established in the year 2011, is attached to the Malabar Medical College, Hospital and Research Center, which is established in the year 2010 as the first private medical college in Kerala, currently with 200 MBBS seats. Our campus is situated 22 kilometers away from the Calicut city. The competent management of this institution provides all the facilities for academic and co-curricular activities. The Malabar Medical College Hospital and Research Center offers builds facilities to enhance learning of nursing students as the clinical practice setup with a 90-bedded super specialty hospital with various departments. We have got a very good response and about 900 people registered for our webinar. We have arranged the session in Zoom platform and YouTube live streaming for the smooth conduct of the webinar. All the participants are requested to mute their mic to prevent interruption during the webinar. Those who attend YouTube live streaming, put your queries as comments so that the moderator will note the comments and will be intimated to the resource person. Now, let's begin this program. Let me call Mrs. Jinsi PM, Assistant Professor, Department of Obstetrics and Gynecological Nursing, Sree Anjaneya College of Nursing, for the welcome speech. Welcome you, ma'am. Over to you, ma'am.
A warm good morning to everyone. Today, I am here to welcome you all for the national level webinar on cervical cancer on behalf of Sree Anjaneya College of Nursing, MMC Campus, Calicut, Kerala. On this auspicious occasion, I would like to welcome Honorable Resource Speaker Dr. Pallavi Shukla, who is currently working as an Assistant Professor in Preventive Oncology, AIIMS, New Delhi. We believe this is an excellent opportunity to learn from you and be inspired to think beyond. I heartily welcome you, ma'am. On behalf of everyone, I would like to extend a warm welcome to our respected principal, Dr. Professor Jolly George, who acted as a pillar of support and strength with clear vision and passion entwined with novelty in all activities of the college. I welcome you, ma'am. Now I take this opportunity to welcome all the dignitaries in attendance, and your presence will definitely enhance webinar's value. At this special moment, I would like to welcome all the attendees. We appreciate your willingness and enthusiasm to participate in this webinar. Thank you for giving me the opportunity to contribute to this webinar. I hope all of you will enjoy this session. Have a good time. Thank you. Over to Ashwini.
Thank you, ma'am. It's my honor and privilege to have such an eminent and eligible person with good experience in the field of education as our principal. Your endless care, guidance, and support prove that you are a great leader. With thankful heart, I extremely privileged to welcome our beloved principal, Dr. Professor Jolly George, Sree Anjaneya College of Nursing, for inaugural address. Over to you, ma'am.
A warm good morning to one and all. It's my privilege and honor to be the chairperson of today's national webinar on cervical cancer. As we all know, cervical cancer ranks as the second most frequent cancer among women in India and the second most frequent cancer among women between 15 and 45 years of age. The month of January is observed as Cervical Cancer Awareness Month, and it's a time to talk about how HPV vaccine can help prevent cancer. As a part of Cervical Cancer Awareness Month, we want as many as possible to know how they can reduce and prevent the risk of disease and educate others. On this background, we, Sree Anjaneya College of Nursing, would like to host this nationwide webinar, and I am so glad and blessed to have an expert in this field to bring about the session today, Dr. Pallavi Shukla, Preventive Oncologist, AIIMS, New Delhi. Thank you so much, Madam, for accepting our invitation. And I acknowledge the support of Mr. Matthew Varghese, my former student, and he's currently working as the nursing officer at AIIMS. And also, I would like to express my gratitude to the patron, the chairman of Medical Trust, Mr. Anil Kumar V, for his extensive support to conduct this webinar. On this auspicious moment, would like to declare that the National Webinar on Cervical Cancer is officially inaugurated. I welcome you all the participants on behalf of Sree Anjaneya College of Nursing. Thank you. Over to Ms. Archana.
Thank you, ma'am. I'm profoundly delighted to take an opportunity to introduce the resource person for the day. She is none other than Dr. Pallavi Shukla. Dr. Pallavi Shukla is currently working as Assistant Professor in Preventive Oncology at Dr. B.R. Ambedkar Institute, Rotary Cancer Hospital, AIIMS, New Delhi. She did her MD in Community Medicine and Public Health from King George Medical University, Lucknow. Coming from a public health background, her exemplary works have been study on health status of female sex workers, study on insulin resistance and smoking, and rotavirus vaccine trial. She did her PhD from AIIMS, New Delhi, and was awarded Best PhD from RP Center, AIIMS. As research officer in RP Center, she has been actively involved in operational research on strengthening primary eye care, national level surveys on blindness and trachoma. She was a member of National Task Force Committee on developing guidelines on primary eye care and national trachoma elimination. She is a life member of Indian Public Health Association, All India Ophthalmological Society, and Asia Oceania Research Organization in genital infections and neoplasia. She is also a member of Technical Resource Group under National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke for Delhi State. Her areas of interest primarily involve common cancer prevention, especially breast, cervical, and oral. Welcome you, ma'am. Over to you, ma'am.
Thank you so much, and I'm really delighted to be a part of this webinar. I'm extremely grateful to Sree Anjaneya College of Nursing for having me here today, respected Principal Madam, and all the members of the organizing committee, and with a special thanks to my brother, Mr. Matthew Varghese. So I would like to congratulate Sree Anjaneya College of Nursing for taking up this important topic as a webinar. And since we all know that January is celebrated as the Cervical Cancer Awareness Month, and the reason why we are celebrating this as a Cervical Cancer Awareness Month is because this cancer needs a lot of awareness. And one day is not enough to create that, right? So we are dedicating an entire month to have all the activities just streamlined for this purpose. So cervical cancer, we are aware that it is among the two most common female cancers in India. So a lot of work has to be done. Although we are seeing a declining trend in this cancer, still a lot of work is needed and many more hands are needed to really go forward with the goal of eliminating cervical cancer from India and world as well. So with this note, I would like to share the screen and carry forward with my presentation. Although it kind of becomes a little monotonous, if I keep on speaking for 1.5 hours continuously. So what is the suggestion of the organizers? Should we take up some questions in the in between, or shall we restrict it towards the end?
Okay, ma'am. Sure, ma'am.
So what is your take on this?
Ma'am, you can have it in the end. I hope so. That will be good.
The end. Okay, so can we have some cameras open at least?
Yeah, sure,
I'm
ma'am.
able to see the participants and their reactions.
Yeah, sure, ma'am.
Okay, thanks. So the topic that I've chosen today is cervical cancer elimination by 2030. That's what WHO is aiming at. So before we go ahead with this topic, let's just have a brief, understanding of what do we mean by elimination. So there are three terms that you might have come across. One is eradication. So India has, the world has already seen the eradication of polio, the eradication of smallpox. So by eradication, we mean that we are, we have got rid of the infectious agent from the environment as well, right? So that is complete eradication. A step earlier is elimination. So by elimination, we mean that the disease is no more exists as a public health problem. It will not cease to exist. It will be there, but it will not be a public health concern. It will not be happening in those large numbers. So we are aiming at cervical cancer elimination by 2030. So that's how I've planned my session today. First, I'll be discussing about the cervical anatomy, the gross and the histological. And then we'll talk about what are the WHO cervical cancer elimination initiative, why there is a need for a global strategy, what is the burden of cervical cancer, what will be the path to elimination, the various levels of prevention which can be associated with this cancer, the strategic actions planned, what is the role of HPV? What is HPV oncogenesis? The risk factors for cervical cancer? What is the symptomatology? And how can we prevent it through vaccination and through screening and early detection? So let's just have a look at the anatomy of cervix. So this is the cervix that we visualize either through a per speculum examination or under a colposcope. So what do we see here is a pinkish area outside, which is actually lined by a squamous epithelium, and this we call as the ectocervix. This is the part of cervix which is actually present within the vaginal wall. The lining which we are seeing within is slightly more reddish. This is the endocervix. This is actually the inner columnar epithelium. As we know, all our internal organs are lined by columnar epithelium. And whatever portion is outside, that is lined by a squamous epithelium, because outside areas require more, stability, they need to be more resistant. So that is one reason why in the outside we have squamous epithelium and inside we have columnar epithelium, because columnar epithelium will have lots of glands and all. So the lining, the junction between these two epithelium, the point where these two epithelium meets, this is the squamo-columnar junction. And it has got a very important role once we'll come to the other slides now. So what happens here is, so this is the ectocervix, the part of the cervix which is within the vaginal wall. And this is the endocervix, an endocervical canal, the part of cervix which is inside. So this is lined by the columnar epithelium and the ectocervix by the squamous epithelium. And this blackish portion at the junction of these two epithelium is the squamo-columnar junction. So this thing keeps on changing as we advance in our lives. So before puberty, if you look at somebody's cervix, how will it appear like? So this is the os, which will be very pinpoint oval, right? And it will be surrounded by the original squamo-columnar junction. During the reproductive period or after puberty, what happens? The os also starts to, become more transverse, and the columnar epithelium, it starts to protrude out. So once the columnar epithelium starts to protrude out, the original squamo-columnar junction goes beyond that. So you see the squamo-columnar junction going outside. So this area between the os and the squamous-columnar junction, this is all columnar epithelium. And this one is the squamous epithelium, the outside area beyond original squamous-columnar junction. What happens during childbearing periods? This os will become more transverse and more gaping. And because the columnar epithelium is now present within the vaginal wall, it is exposed to the vaginal acidic medium. That's why the columnar epithelium will not remain columnar anymore. It has to become more resistant epithelium. So it will convert. So that will convert, there'll be some metaplastic changes happening, and that will be becoming more squamous in nature. So that way, the original squamous-columnar junction has been pushed to the periphery. A new squamous-columnar junction will appear just outside the os. So here between the os and the new squamous-columnar junction, you are seeing the columnar epithelium. Between the new and the old squamous-columnar junction, you will be seeing a zone which is marked gray in color in the diagram. This is the transformation zone. And beyond this is the squamous epithelium. So basically, this is the portion which is most vulnerable to development of cervical cancer, this transformation zone. That was my sole purpose of telling you about the anatomy of cervix, because this transformation zone is very important once we are screening a woman for development of any cancers. If we are looking for early changes, we need to see this transformation zone in its entirety. And this is the place where all the cancer is happening. Why? Because metaplastic changes are reversible changes. So one mature epithelium converting into another mature epithelium, that is metaplasia. But that again is a reversible process. If you do away with the agent which caused that change, so here in this case, it's the acidic environment of vagina. So once you remove that agent, it might revert back to its original epithelium. However, if this change continues to happen, and if there is some more stressors wherein there are more frictional changes, there are more insults happening in this area, what will happen? This metaplastic changes will convert into dysplastic changes. So those are the things that we see while we are doing pap smears and colposcopy. So this transformation zone is of utmost importance. Now, what happens in the perimenopausal period or in the menopausal period? This columnar epithelium, which was earlier visible, it starts to recede inside. So sometimes it becomes very challenging to do a visual examination for a woman in a menopausal period, because we are not able to see this transformation zone in entirety, because the new squamous-columnar junction has receded within the endocervical canal. So these were some important points to be considered. That's why I took up this anatomy prior to starting our topic. Now let's what WHO is planning to do with cervical cancer elimination. So this is the first time that WHO has ever come with a global strategy for elimination of any cancer. And in May 2018, the Director General of WHO, he called for a global action to eliminate cervical cancer. And by August 2020, the World Health Assembly adopted a global strategy for cervical cancer elimination. The target for elimination kept is, like, by elimination, we mean that the disease will exist, but it will not be a public health problem. So that means what will be that cutoff value that will be bearable? So that will be less than 4 women having cervical cancer per 100,000 women years. So less than 4 per 100,000 women years. When we come to this incidence, we will consider our goal is accomplished. So why do we need a global strategy for cancer elimination? Like, every country should take up their own strategy and they should work on it. Why do we need a global strategy at all? Why is WHO taking so much concern in this regard? So first and foremost, the high burden of this cancer. So globally, it is 4th most common cancer among females. And in India and other low middle income countries, it is either number 1 female cancer or number 2 female cancer. And the dilemma of the situation is that it is the only cancer which is preventable. Yes, this is one and only cancer which is preventable. None of the cancers are preventable. We can detect cancers early, we can improve survival in other cancers, but this is one cancer which we can prevent from scratch. It is curable if it is detected early and treated adequately, and yet it is the most common cancer. That is why WHO is intervening. Second reason why WHO has to intervene is because of the global inequities. So why the Western counterparts, their cervical cancer is not a major concern? If you look at the list of female cancers, the cervical cancer would be somewhere around 10th or 11th in number in the ranking. However, in our scenario, it is either number 2. In African countries, it is number 1 cancer. So there is wide global inequity in this cancer. So that's why we need to redistribute the resources and work together for its elimination drive. That's why WHO had to intervene for a global strategy. Now, what are the targets? Okay, before we move on to the targets, let's have a look at the world statistics. So as per the Globocan 2020 data, the estimated number of new cases among all females, we see number 4th, the cervical cancer, with more than 600,000 new cases happening each year. In 2020, it was estimated as 604,127 new cases. And if we look at the number of deaths, so out of all the cases, I think 50% are dying because of it. So, but out of all the deaths due to cancer among females, 7.8% is happening because of cervical cancer. Now see how the statistics differ for India. Here, cervix uteri ranks number 2. And that is because of various reasons that we have worked so hard on it. Earlier, cervix uteri cancer was number 1 female cancers in India. Now it has been reduced to number 1 female cancer in certain pockets, in certain districts, in certain rural settings. However, by and large, breast cancer has taken over cervix cancer in almost all urban urban cancer registries. Now, let's see. So this is the ranking of cervical cancer. So you see, these African countries, the Southeast Asian countries. So everywhere here, either cervical cancer is the first or the second most common cancer. And if we look at the death, again, a similar kind of profile is seen. However, if you look at our Western countries like the England and group, Americans, the Canadians, so there, the cancer is somewhere around 10 to 20th in ranking. So what is WHO's life course approach to cervical cancer control? So as I said, this is one and only cancer which can be prevented. And by prevention, I mean at all levels of prevention, there are preventive strategies for cervical cancer. So we have primary prevention strategies, we have secondary prevention strategies, we have tertiary prevention strategies. Now, I hope you are aware of what are these 3 levels. Maybe I'll just give a quick recap of it. By primary prevention, we mean that the disease has yet not happened. The risk factors might be there, but the disease per se has yet not started. If we intervene at this level, this becomes our primary preventive strategy. So what is the primary preventive strategy for cervical cancer? Vaccinating our girls. So vaccinating the girls before they are exposed to the HPV virus, before their sexual debut, if they are vaccinated, they are made ready to combat HPV infection, we are giving them primary prevention. That is why I say that this is the most preventable cancer. The other things that are to be kept in mind is that at this young age of 9 to 15 years, they must be educated about a healthy sexual life, about menstrual hygiene, about and even about tobacco, non-initiation of tobacco, because tobacco per se has been found to be associated with cervical cancer. So it's a known risk factor for cervical cancer. And all these things, they should be taught early in the life before they are yet to begin their adult life. So health information, warning about tobacco usage, sexuality education tailored to age and culture, and then about healthy sexual practices and male circumcision if it is allowed in their community. So that prevents cervical cancer among the female partners of people who are circumcised. What is secondary prevention? Secondary prevention is the level of prevention wherein the disease has just started to happen and we are able to, identify it early and cater to it early. So early diagnosis, early management, that is secondary prevention of any disease. So what secondary preventive strategy we have for cervical cancer? It is screening, early detection. And there are so many, techniques available for screening cervical cancers. Just screening might not be enough for a country like ours, wherein people hardly get a chance to visit their, health practitioner. And once a patient has come to you, there's no guarantee that the patient will ever come back to you again. So for a place like ours, for a low resource setting like ours, the best thing would be screen and treat in a single visit approach. We can't wait for them to come back again. There are so many stigmas associated with cancers. There are so many, socio-demographic factors which are, playing a role that people might not turn back to you again once they hear the C word. So best would be the early lesion. If picked up early, they should be treated at that very instance. Then, adopting the point of care rapid HPV testing, because the other kind of testing, the screening methodologies that are available, that take time for the result to come back, right? So be it pap smear, be it even HPV, if the center is not equipped with the facility, it might take a long time for the results to come back. So we need something which is a point of care, rapid HPV testing. Woman comes, you test her, within an hour you get the result, she's waiting there at the counter, and by that time you are there with the result and you can go ahead with the procedures. Other test which is very apt for screen and treat is VIA, and we will be talking about it later in detail. That is visual inspection with acetic acid. So there are many, these screening techniques which are available. Now, the third level of prevention is tertiary prevention. By tertiary prevention, we mean that the disease process has already set in. So what do we need to do more to make the person, to improve the quality of life of that person to as normal as possible? So whatever that we are doing to make the lady comfortable and to regain her routine normal life, that comes under tertiary prevention, and that means early treatment. And this could be a multimodality treatment. So we would be requiring, multiple oncologists sitting on board. So we need some kind of tumor boards so that the lady is benefited by getting all the treatment modalities at one place. So be it ablative surgeries, be it radiotherapy, chemotherapy, palliative care, so everything should be available at the one single point of contact. So what is this WHO's global strategy? It's a world free of cervical cancer. And the goal for it is less than 4 cases of cervical cancer per 100,000 women years by 2030. So we are already in 2023, 7 more years to go, and we have to achieve this target. And trust me, we are nowhere close to it. So the target set for this is 90% of the girls should be vaccinated with HPV vaccine by 15 years of age. 70% of the women should be screened with an HPV test or any test which is at par with it at 35 and 45 years of age at least. And 90% of women who are identified with cervical disease, they should receive treatment for either precancerous conditions or invasive cancers or whatever. So this 90, 70, 90, we need to keep in our minds. Now, these are some of the stats that I would like to share. Like between 2006 and 17, 100 million adolescent girls, they received 1 dose of HPV vaccine. But 95% of this vaccination happened in the high-income countries. Pathology services, cancer surgery, chemotherapy, radiotherapy, so they should be available in the public sectors. We're not talking about the private sector. They need to be present in the public sector. Then only we'll be achieving those targets. And if you look at the current scenario, the high-income countries have 90% of such services in the public setting. However, in low-middle-income countries, it's meager 30%. And similarly, for vaccination also, it is hardly there in national immunization schedules in any low-middle-income countries, not even in our country. So the strategic actions are 90, 70, 90, the rule of thumb within the framework of a national policy. It has to be brought in the framework of national policy. We need a high level of political commitment and stewardship. Nothing can be done beyond it. No matter how much hue and cry we made, we can only bring about small ripples of changes. The good amount of change can only happen if we are able to get good advocacy initiatives at the highest level. The biomedical and the clinical interventions alone will not be sufficient. We need something to, provoke the masses, to make them, aware and pull them to the facilities to be equipped with it. So many levels of public health interventions are needed. The implementation challenges, they will be related to healthcare system weakness. When we are not getting adequate facility for institutional deliveries, then how can we expect that every woman in the country will be screened for cervical cancer? So those are the challenges that we are really tackling with. Then interventions would be differ in urban and rural settings. Probably in urban settings, you would need more of facilities. And in rural setting, we would require more of, awareness drives. So in urban settings, even a flash message would be good enough. The lady, they are so vigilant, they just need to know where the facility is available and they might drop in there. However, in rural settings, we need to pull the patient out of their comfort zones because they do not like the word cancer. And screening for cancer for them is a death sentence. So they don't even want that. So that kind of strategy. So that will be different for the rural and the urban settings. So we need tailored approaches for the vulnerable and the underserved population. Then engaging with the civil societies and public-private partnership is very much needed because we are in dearth of finances, funds. All the testing for cervical cancer, the vaccine, everything is a costly affair. So we need engagement with civil societies and public-private partnerships. Now, one important thing that I would like to bring to notice is that human papilloma virus, HPV, this is the necessary but not the essential cause of cervical cancer. Now, this is a very important statement. You need to understand that. It is a necessary cause, but it is not an essential cause. What does that mean? Every cervical cancer, if you trace back the history, sometime in their lifetime, they would have been affected with HPV infection. They might not be aware of it, but as a hohi nahi sir, I mean, this is just not possible that there is cervical cancer and there was no HPV infection. That means it is a necessary cause. However, it is not an essential cause. So that means all the HPV positive women will develop cancer. That is not happening. So there are certain factors which will cause the HPV positive women to develop cancers. So cancer will require HPV virus infection, but there is something more to it to make it convert into cancers. So what more? The more is the persistent infection with a high-risk strain of HPV. What do we mean by persistent infection? By persistent infection, we mean infection happened and it just stayed there. HPV infection is a sexually transmitted infection. It can transmit by sexual and non-sexual routes. By non-sexual route, we mean the vertical transmission and through the oral routes and all. But more so, it is related to some of the other sexual activity, right? So it is the most common sexually transmitted infection, as common as 70 to 80% of all the people who are sexually active would have encountered this virus in their lifetime. So this is so common. But not everybody is developing cervical cancer. Why? Because as a viral disease, our body is fighting against this infection. Our immune system is capable to do away with this virus within 1 or 2 years. So even if we get infected, within 1 or 2 years, by our natural immunity, we get rid of this infection. For somebody who cannot get rid of this infection and the virus stays back, that is the persistent infection. And if that persistent infection will initiate the process of oncogenesis. And the credit for all this research and all this that I'm telling you about HPV goes to Dr. Harold Zur-Hausen, who actually received a Nobel Prize in Medicine in 2008 for isolating these oncogenic HPV strains. And it is actually his statement that HPV is the necessary but not the essential cause of cervical cancer. So let's have a brief look on how the HPV, this thing, virus looks like. I'm sorry, I'll just have a sip of water. So HPV is a small non-enveloped DNA virus with tropism for squamous epithelium. So this virus, it basically targets the squamous epithelium. And the capsid protein, which makes the outer covering, L1, this determines to which family it belongs to which genera it belongs to, and species and all. So if there is more than 60% of L1 sequence identity, it becomes one genera. If there is 60 to 70% matching, it becomes one species. 71 to 89, it becomes one type. So on and so forth. Till 2016, 205 HPV types have been identified, and they are spread across 5 genera: alpha, beta, gamma, mu, and nu. And okay. So this is how the virus looks like. So we have the early region, we have late region, and we have a long control region. So nothing much to know about it except for the fact that E6 and E7, these two are the main, regions which are responsible for the oncogenesis. So this early region E6, this leads to degradation of a tumor suppressor gene P53. And this is E7, this is an oncoprotein. This is associated with the degradation of P retinoblastoma gene, of human gene I'm talking about. So this virus attacks these two tumor suppressant genes. So once the tumor suppressant genes are eliminated, the tumorogenicity increases, right? So this is how it happens. The virus can never go. So virus has a tropism for squamous epithelium, and that too specifically for the basal cells. Because here, these basal cells are responsible for the division and multiplication of this epithelium, right? So all the mitotic activity is happening here, right? So if the virus goes back down to this level and causes changes here, then only it will transform into a cancer. Now, how will the virus penetrate so low? Squamous epithelium is too rigid, too resistant to all these infections if it is intact. The moment we have microabrasions, they will cause this virus to go deep down to the basal layer, and from here the primary infection, the genome amplification, and the viral maturation and shedding starts. So virus has to go deep down to the basal layer, and that requires some kind of microabrasions in the cervical epithelium. So are you getting my point? So what do I mean by all these? So these are the risk factor which are causing the virus to stay back. These are the risk factor which are causing persistent infection, which are causing virus to cause changes in your histologic anatomy. Now, what causes micro invasions or abrasions? We'll talk about it later. So as I discussed earlier, it is the most common sexually transmitted infection, and humans are the only natural reservoir. We don't have any animal reservoir. It is not transmitted through mosquitoes, thankfully. The transmission modes are either very intimate skin-to-skin contact with an infected person or auto-inoculation from one body side to another. Then vertical transmission is possible, which causes juvenile respiratory papillomatosis in the infants, and high communicability during both acute and persistent phase. So the most, common route of transmission is the sexual route of transmission. Other than that, we have other means like autoinoculation and vertical transmission, etc. But most common is sexual route. So primary risk factor, what do you think could be for cervical cancers? It is related to sexual behavior. So early sexual debut, multiple sex partners. So what is happening? So the moment you are giving more lifespan to your sexual behavior, you are more exposed to those micro abrasions. Then changing of partners will cause change in your exposure to the particular kind of HPV strain. If somebody is in a monogamous relationship, both the partners are faithfully in a monogamous relationship, the only viral infection that can happen between two of them can be one strain of HPV, right? The moment there is more number of partners from either side, they will be exposed to another strain of HPV, right? So once you are affected with COVID, were you immune to the second wave of COVID? No. So because as the strain changes, your immunity to that virus depletes. So that is the crux. So that is why we say that multiple sex partners and all this is a risk factor for having cervical cancers. Then other risk factors are higher number of pregnancies. Again, what is higher number of pregnancy doing? Pregnancy hogi, childbirth hogi, there will be trauma to that region and there will be microabrasions. Other STIs, so other sexually transmitted infection, they will cause inflammation and injury to that area. So they will make viral penetration more easy. Even smoking will reduces the defense mechanism, the natural defense mechanism of our body, the epithelial lining and everything. So that kind of protective mechanism is lost because of smoking. There is some role of genetic factors which is yet to be explored. It is not very well documented that what genes are playing a role, but yes, scientists are working on it and there could be some genetic factors playing some role here. But we are yet not sure about it. Then lack of circumcision in male partners. So actually circumcision will not cause the virus to stay in the male partner. So it will not cause the virus to go into the female partner, right? So that is the basic idea of circumcision's protection. And then poor menstrual hygiene. So all these things, now I am sure it makes sense to you why these risk factors cause cervical cancer. Now, let's talk about HPV vaccination. So first and foremost, it needs to be very clear that when do we advise HPV vaccination? Any kind of vaccination, when do we advise that? We give vaccine for measles, mumps, and so on and so forth. So many, preventable diseases to our kids. We give them the vaccine before they are exposed to that disease agent, right? So vaccine is effective only when it is given before the exposure of that disease. What is the disease exposure in cervical cancer? It is HPV infection, and that is happening because of sexually transmitted infection. So ideally, vaccine should be given prior to that sexual initiation, right? So it needs to be given before 15 years of age. Now here, these guidelines are made on the basis of, what happens by and large, what happens most of the time. But once you are prescribing things, they can be tailor-made. Now, if you are very sure that the girl is, more than 15 years of age, but I'm very sure that she is still a virgin, why should I give her the benefit of vaccination? Why should we refrain from that? Right? So for that reason, even after 15 years, we give them vaccine. So before 15 years, 2 doses are sufficient because there's a longer time for them to start the family life. After 15 years, because we are in a hurry to give them that kind of efficacy, we give them 3 doses. So 2 doses if we are vaccinating prior to 15 years. And once a girl completes her 15th birthday, she is eligible for 3 doses of vaccines. So the 2 doses. So one thing which needs to be very, important for you to understand is the dosing interval. So we should not be in a hurry to give vaccine as early as possible. At least 6-month gap should be there between 2 doses for the efficacy to happen to the optimum extent. We should not be in a hurry कि नहीं हम 4 महीने में ही दे देंगे. No. We need to have at least an interval of 6 to 12 months. If the interval is a little more than 6 months, that won't be harmful. But an interval less than 6 months might not give you the same kind of efficacy. So second dose, ideally, if you give a vaccine 0 dose today, after 6 months, you should be giving the second dose. By chance, if there is some problem happened and the girl couldn't come at 6 months, she can come at 7, 8, 9, 10 till 12 months. And after 15 years, the recommended schedule is 0. Then after 1 or 2 months, depending upon the vaccine which she is being given, and 6 months after the first dose, you are giving the third dose. So 3 doses are recommended for immunocompromised people. So those HIV infected people, those who are on chemotherapeutic drugs for any other cancer, those who underwent renal transplantation and are on immunity suppressant drugs. So in that case, whether the age is less than 15 or more than 15 years, we still give them 3 doses. So what are the available vaccines as of now? As of now, we have Gardasil, which is a quadrivalent vaccine. This was licensed in 2006. Then there is a bivalent vaccine, Cervarix, which was licensed in 2007. And now we have Gardasil nonavalent, 9 strains. It covers 9 strains and it was licensed to be used in 2014. All these vaccines they are highly immunogenic and more than 98% antibody response happens within 1 month of the dose. However, there is no correct way to find out whether, there are no titers available that we can say, okay, if this much titer is there, the woman is protected, right? So we don't have any serological correlate of protection. High efficacy protection from vaccine. So for strains for which the vaccine is made of, for that particular strain, you will get high efficacy. There could be some cross efficacy for other strains also, but not to that extent. So by bivalent vaccine will cover HPV 16 and 18. Quadrivalent will cover 6, 11, 16 and 18. And nonavalent will have 31, 33, 45. So approximately 9 strains. Now, all the 3 vaccines are almost equally efficacious because, why I'm saying this, because in India, HPV 16 and 18, they cause more than 85% of cervical cancer. They are responsible for more than 85% of cervical cancers. So if 16 and 18 is covered in any of the vaccine, you are taking care of a larger chunk of cervical cancer. At least 16, the lady will not have cervical cancer because of 16 and 18. That's sure. Now, what are the contraindications to vaccination? So severe allergic reactions have been noted, but to a very small extent, like it is associated with any other vaccine. Then immediate hypersensitivity to yeast, because Gardasil contains yeast component. anaphylactic reaction to latex in case of cervix. So some kind of moderate to severe acute illness will be noted. So we had that kind of illness even in COVID vaccine. Pregnancy. So is pregnancy a contraindication? So the thing is, to require a pregnancy testing before vaccinating anyone. Okay, so that means it is not an absolute contraindication. Even if somebody is pregnant and accidentally you have given her one dose, nothing will happen to the fetus, so we need not terminate the baby. However, we will not continue with the vaccination schedule till the delivery has happened. So we will refrain from completing the schedule. If by chance you have given her one accidental dose, nothing will happen to mother or baby. But it's better to continue with the schedule after the delivery. Then adverse reaction, 20 to 90% of time, it's just local reactions, 10% it's fever, and very few like nausea, dizziness, malaise kind of thing. So there are no serious adverse effects. What is recommended is you give the girl at least, what has happened to the slide? Why these markings have come up? Somebody has used annotate, I believe. So, serious adverse events are associated, but still we give them an observation period of 15 minutes to half an hour. So we ask them to just lie down or just sit down, because at times they have some syncopal attacks and all. So it's better that they have some resting period after vaccination. Now, IAP, the Indian Academy of Pediatrics, they recommend that HPV should be recommended, is a recommended vaccine by them. So 2 doses at 6-month interval between 9 to 14 years and 3 doses from 15 year onwards. Foxy also says a similar thing. So all our guidelines, if you say the all the society guidelines, they are favoring HPV's inclusion in the immunization schedule. But it is not happening per se. Why? The only reason is the cost associated with it. So the nonavalent HPV, the Gardasil nonavalent, that cost around 8,500 per dose. So that is not affordable for government to give in the national program. Even the bivalent the quadrivalent Gardasil also, this again is costing around 2,800 to 3,500 per dose. So this is not at all a cheap vaccine. However, there is a ray of hope. Recently, Serum Institute of India, I'm sure somebody must have read it in the highlights, that Serum Institute of India, the same Cyrus Poonawalla group which had made the indigenous COVID vaccine, they have announced that their HPV vaccine, the quadrivalent HPV vaccine, will be available, I think, this year itself. So this will be covering 4 strains, 6, 11, 16, and 18. And this will reduce the cost immensely. As per the interview given by Poonawalla, it would be somewhere around 200 to 300 per dose. And the moment that the cost will come down to that level, probably many state governments will be thinking about taking it up in their national programs. Now, let's see what is the HPV's pathophysiology. So this is the normal cervix, and then the lady, gets infected with HPV infection. However, it's a long process to happen. It takes around 10 years for the precancerous lesions to develop. And again, approximately 3 to 5 years for an invasive cancer to happen. So actually, this long window period is what makes this cancer most preventable, again, apart from vaccination. Till now, what we were doing a PAP test. PAP test was able to identify somebody at this stage, right? Or even VIA, or even whatever means that you were taking to screen cervical cancer, that was happening at this stage. With the introduction of HPV DNA testing, we are adding 10 more years to a woman's life, because she will get to know her status right at this stage. So if somebody is HPV positive, they will be more conscious, they have to get themselves screened religiously as per the recommended guidelines. So we can at least leave the ladies who are HPV negative for a time being. At least for coming 5 years, they need not worry. After 5 years, HPV test will be repeated. And if those HPV negative have become HPV positive now, then they can also come into the screening pool. So HPV is giving you 10 more years of additional benefit. Now, what are the signs and symptoms associated with cervical cancers? So there is irregular or intermenstrual bleeding, right? Post-coital bleeding, post-menopausal bleeding. Then there is blood-stained vaginal discharge, pain during intercourse, pain in... So all these symptoms, if you see, they are not very specific. They can occur in any of the gynecological conditions, but they are a marker that something is wrong. If not cervical cancer, some other gynecological condition. All we have to do is not to leave this lady for screening. We have to get this lady screened. Although screening should be done in asymptomatic women as well, but inko to bilkul nahi chhodna. But we should not leave these women. We have to make them undergo a screening test. Then pain in lower back and thigh, passage of urine and stool per vagina. These things will happen when the cancer has, grown a lot, and it is caused, the tumor burden is causing these pressure symptoms. Then anorexia and weight loss, as with any other cancer, this is one of the sign and symptom. So what are the screening modalities that we have? So one modality, the age long, everybody knows that, and very nice technique, that is pap smear. So that is cytological screening. So it's a conventional pap smear, or recently we have some additions to it, like we have liquid based cytology. So in pap smear, what we used to do, we used to take a scraping, put it on a slide and send the slide in a fixative to the lab, and the pathologist would tell whether there are any abnormal cells in the smear or not. Problem with the conventional pap smear was that because of the expertise of the person taking the smear, sometimes the smear was not very effectively read. So if you had made a thick smear, pathologists will find it difficult to read what has come in the smear. So that way it was very much, observer dependent. So with liquid-based cytology, we get an edge. How? Because even the liquid in which we are sending that slide. So we first take a smear, we make a smear on half the slide. On half the slide, from the brush, we just scrape it off. And then we put the slide in the liquid medium. So that liquid medium now will have some cells, the cells which we had smeared on the upper edge of the slide. So that will come in the liquid, and that liquid will be tested for abnormal cells. Then there is automated cytology. You don't even need somebody in the pathology department to be doing that test. It will be done by the machine automatically. So these are the advancement which has happened. And then there is HPV testing. We are testing for HPV DNA in the smear. Again, we are taking a cervical sample. Cytology screening, we need to repeat. Oh, please don't do these annotations. Okay. So for pap smear, we require a 3-yearly screening interval. So somebody who screened with pap test needs to get the test repeated after 3 years if she was screened negative last time. For positive, we have a different flowchart. For HPV testing, this screening interval has been increased to 5 years. Same goes with co-testing, like we are doing HPV and cytology together. That increases the sensitivity of the test. That again happens every 5 years. And now what WHO recommends now is at least twice in a lifetime, 35 years, 45 years, if we are doing HPV testing, that is also good enough. Then there is a test called visual inspection with acetic acid, wherein you don't require anything. You just take a swab, dip it in 5% of acetic acid, and just rub it over the cervix and just visualize it. If there's whitening, that means there is pre-cancer or cancerous lesion. Similarly, the VILI, visual inspection with Lugol's ID. So these two techniques, VIA, VILI, these are important in low resource setting, wherein we don't have access to pathology services, or it takes long time for the reports to come from pathology. So VIA and VILI, they provide you instant results. Then there are certain newer modalities like testing for biomarkers. We can test for high-risk messenger RNA, then P16 staining, markers of proliferation, etc. Excuse me. So this pap smear, this technique was given by George and Papanicolaou in 1940. So it's so old. However, it is very effective in reducing mortality by 70%. And you can start pap smear screening from 21 years onwards, provided the person is, sexually exposed. And it is to be repeated every 3 years. Prerequisites are that no tampering should be done with the, with the vagina, with the cervix prior to this testing, at least 48 hours prior to it. No douching, no use of tampons, no vaginal medications, and no intercourse. That will interfere with the test. And test cannot be done in female who are pregnant, who have undergone abortion recently, menstruation is happening, and who are already known cases of cervical cancer. What are we doing with that? Right. So wherever a per speculum examination is not doable, we do not do this test. So this is the liquid-based cytology that I was talking about. So this liquid contains those cells. You put it in the centrifuge. The cells will, settle down, and then we do a cell block and all, and we prepare a thin prep slide. So this will have a better result than your conventional pap smear. Then this is the HPV DNA testing. So these are the vials. This comes directly from the manufacturer. They will send you a vial with a brush and in a sterile packing. And you will require an assistant to do this test because and a good, Cusco self-holding speculum. So somebody really need to hold that. We can't just do it with a manual holding speculums. We need a self-retaining Cusco speculum. And so basically, we are trying to detect any kind of HPV DNA in those cervical samples. The HPV testing is that self-sampling is allowed. Because I know for many of us, I'm sure, even though we are aware about the screening methodology for cervical cancer, even though we know everything about it, we have access to this service also, still, we do not really come forward for cervical cancer screening. Sometimes there is, some kind of embarrassment, some kind of hesitancy in undergoing that per speculum examination. Or maybe, visiting the consultant whom we are seeing day in and day out and getting ourselves screened with that lady. So those kind of apprehensions that can be taken care of if we give them an opportunity to do a self-sampling. So for self-sampling, there'll be a different kind of brush. So like we insert any kind of vaginal pessary, similarly, we'll just insert this brush. These things will tell us up to what extent we need to go high up in the vagina. And then we'll just rotate the brush and take the scraping, put it in the vial and send it to the lab. So self-sampling will definitely make life much easier for females. And this has actually started to happen in Western countries. So they can even, the vials are being sent to the ladies through postal services. And those services, they're using those services to send back the sample to the lab and they get the result. So there is actually no contact with the lady. So it's actually a good screening technique looking at the COVID pandemic that we faced, wherein it was so difficult to pull people out for screening services, right? So HPV self-sampling is a good way out. However, it is very costly again. Then sensitivity is at par with the clinician collected sample, 60 to 90%. Specificity is also 88%. Advantages I told you, so it's more acceptable. Now, this is the visual inspection methods. Why it is important for you is you won't be getting this examination done, but you are the people who will be assisting us in doing these examinations. We need more hands for cervical cancer screening. Abhi tak, till now, whatever we have covered, that was for your awareness. But here, we want some, some motivators, influencers, and go-getters who would really take this forward, because this thing can be done by our nursing community and it will be a leap for us. If the nursing community starts cervical cancer screening, that nothing can be more good than that. So why? Because if you look at the primary health settings, I'm not sure about Kerala, but here in our states, in North India, I have seen the medical officers, what they're doing, they're just seeing patients, they are just giving them treatment. Most of the, these procedures concerned with per speculum examination, that is done by our ANMs, that is done by the nursing people. So they are doing the copper T insertions, they are doing so many things which requires per speculum examination. And visual inspection requires just a per speculum examination, nothing more than that. It is absolutely a low cost technique. So what you need an examination table available everywhere, a light source available everywhere, bivalve speculum available everywhere, and an instrument tray with cotton swab, examination gloves, acetic acid, chlorine. So everything is there. All that you need to arrange is acetic acid. And this acetic acid need to be freshly prepared. That is the only prerequisite. So acetic acid, it is very hygroscopic in nature. So if you leave it for a day, it will absorb all the moisture from the environment and it will not remain to the dilution that you had made it for. So you would have made it for 5% dilution, but it would become 0.01% after 2-3 days. So that is why it needs to be freshly prepared. So for that, you need 5 ml of glacial acetic acid, 100% acetic acid, and you dilute it with 95 ml of distilled water. If distilled water is not available, even RO water is good enough. So that's the only thing that you need. And what happens, you will just do a quick vaginal examination. We don't recommend doing a per vaginal examination prior to taking samples. However, you can just have a routine inspection of the external genitalia. Then you insert the speculum without any lubricant, and then you visualize the cervix. Now I go back to my first slide where I showed you the transformation zone. So that transformation zone should be pretty much obvious to the entirety. It should be totally visible. If it is not totally visible, you have to do certain maneuvers to make it more visible, right? So only when you can see it fully, then only your test will be 100% accurate. Then you take a cotton swab and remove the extra discharge, whatever is there in the cervical area. Take another cotton swab, dip it in your acetic acid solution, and then take that soaked a sponge or swab, and insert it, put it on the cervix, just move your hand a little bit so that it covers the entire cervix, and just stay there with the swab stick for 1 minute. Yeah, the person who is assisting you will be looking at the watch. The moment it is 1 minute, you pull it out and just wait for some time, another minute or so, and then you visualize the cervix. So if there is some precancerous lesion, if there are some invasive cancers, it will be pretty much obvious as a white thing. So that's what happens in cervical cancer. So acetowhitening is what we are looking at. I'll just show you some pictures. So this is not acetowhitening. This is just an ectropion, the internal columnar epithelium which has come out. So this is not the white areas. This is not white. This is pale but not white. This again is not white. So it has to be a well demarcated white area. So all this which is appearing pale, this is not acetowhite. It will be chalky white and it will be well demarcated. Now this thing that you are seeing whitish. This is actually a Nabothian follicle, which is a normal physiological condition. This is a trichomonas infection, this pinkish reddish dots. However, this again is not white, aceto-white. This is the whitish discharge, but not aceto-white. So this is the kind of aceto-whitening that I'm talking about. So this kind of aceto-whitening will appear. Well demarcated and chalky. Again here, the upper lip, lower lip. Here again, this streak here again. So these are the kind of lesions that you will see in the VIA examination. This is invasive cancer, which is bleeding on touch. Then the way we are seeing aceto-white areas by acetic acid, similarly with Lugol's iodine, we'll be seeing this color. So squamous epithelium, it contains glycogen, but precancerous lesions and invasive cancers, they will not contain glycogen. The glycogen containing areas will turn with iodine, what will happen? They will become bluish black in color. However, the cancer will not take up the stain. So this will actually reversal of what you are seeing in VIA. So the portion which has not taken up iodine is the cancer. There, the portion which had taken up the whitish color was cancer. So anyway, both are very similar, VIA or VILI, and they are very simple, easy to learn, very low cost, and all levels of health workers can be trained to do that. The results are available immediately. So you can do a single visit, screen and treat also here. Limitations are that it is very subjective. If you have not done a lot of these tests, you will not be able to make out which is the real aceto whitening and which is not. So it has got a moderate specificity. You will be referring more number of women who are not even having precancerous or cancerous lesions. So, but still I would say for a country like ours, which has got so many disparities in terms of healthcare across states, across regions, I think this is still a very good enough tool for cervical cancer elimination strategy. Not everywhere we can provide HPV DNA because it requires lab support. It is very costly. There again, the lack can contribute to loss of follow-up. And because it is so sensitive, it will cause unnecessary colposcopies. Because the moment she is positive, you have to make her undergo colposcopy. And positivity chances with HPV will be more. It's unnatural, right? Then, however, good thing about HPV, it is automated, it is standardized, it is very objective test, high sensitivity, good specificity. And your screening interval is increasing. So it's no more 3 years, it becomes 5 years or even more. So this is the sensitivity, specificity of all the tests together. And I am not sure if you're aware, but we have a national program which runs for cancer control, that is National Program for Prevention and Control of Cancer, Diabetes, Hypertension, and Stroke. So all these 4 diseases have been clubbed together as non-communicable disease, and we have a single program which is catering to all these diseases. Even the COPD and chronic kidney diseases are also added to the pool because they share a similar risk profile. That's why these diseases have been clubbed together. So as per that program also, they are recommending VIA screening for women 30 to 65 years of age. And if on screening, she comes out to be negative, so she is recalled after 5 years. If she is positive, she'll either undergo a screen and treat approach, the lesion will be taken care of there and there itself, or she will be posted for colposcopy with or without biopsy. So this is how a colposcopy is done. So this is nothing but a magnified view of the cervix with the help of a colposcope. So colposcope is just giving you a magnified view of the cervix. So even for doing VIA, if you use a colposcope, it will increase the sensitivity and specificity. Sorry. So these are something for when do we do a screen and treat thing. And if you want to do a little more reading, you can just refer this link. This gives you nice atlas of all the pictures for VIA and all other resource material that can be seen for cervical cancer. I think that's all from my side. Now I'm open to take questions.
Thank you, ma'am. Thank you for the informative and energetic section. So in today's webinar, discuss detailedly regarding the anatomy of cervix and WHO cervical cancer elimination initiatives. What all are the WHO approaches to the cervical cancer control, like primary, secondary, and tertiary? Its signs and symptoms and the vaccines available all. So it was really energetic section, ma'am. Now the section is open for discussion. Those who have any questions can unmute the mic and put your doubts on the chat box. Others kindly mute the mic.
Madam, thank you so much for your valuable and very informative session which you have given. We have gone in depth of the cancer, cervical cancer, that all the cytology, everything you have described very well. You're very much blessed to have a session like this one. See, I would like to ask Corey. I'm belongs to the community health nursing department. So that is why we do have much interaction with the layman, the people, ordinary people. So how we can convince them to take this vaccine, like it is very important, or what is the psychological approach we can do to make them convinced about this one, the vaccination?
So I think it goes both ways. It's very difficult to convince them for vaccine, and it's also very difficult to convince them for screening also. So I guess if both the things are taken up together, that will help each of them. So how can that happen? So I have got a very good experience when we did this program for schoolgirls. So we kept a session for the teachers. We asked the teachers to take up a session for girls. And then we did some kind of activities like poster making, slogan, something, just to keep them engaged in the concept. And then I took a talk for them and told them, so those young minds are more receptive to this thing. Then we asked them to get their mothers for a screening camp. So that was an amazing, response. Otherwise, if you would have gone to a community and asked them to come for a screening camp, nobody would have turned up. So because the girls knew the importance of cervical cancer, they were very much concerned about their mothers, they brought their mothers. And once the mother was there, it was very, relatively easier to convince her that you are undergoing this examination, but your daughter can be saved from this cancer just by a simple shot. So although vaccines were not available with us, so we didn't really put our efforts into it, but I think this channel might work. Plus, we need to have a lot of, mass media messages, because social media is very important these days. I think that will help.
Thank you, ma'am. Thank you for the response. And one more query I have. That's about the use of sanitary pads, tampons, and also nowadays that menstrual cup. There are so much of stigma it's going on regarding use of all those things. Whether there is any relationship between the use of all those things and the cancer of cervix.
So as I said, menstrual hygiene is a very important risk factor for cervical cancer. So till the time the lady is, hygienically very aware, like how she's supposed to use a particular device, till that time, she should not be really venturing into it. If you're not confident that you'll be able to sterilize your menstrual cup properly, better not opt for it. If you're not, if you are keeping your tampons for greater length of time than prescribed or than what is required for your usage, I think you should not go ahead with tampons, because these are the things that you need to be very cautious of. There is nothing wrong with these techniques. The thing which is wrong is how you are sterilizing and reusing them, right? So proper disposal, proper hygienic practices, if you are following, then there's no harm with these techniques.
Thank you, ma'am. So the wise use of all those things which can help to prevent. Thank you, ma'am. Any other questions, participants?
Ma'am, there is a question from Nidhi Nitish. That is, vaccine from Serum India is available in our country or not?
So I already talked about it, that that vaccine is yet not used as a market. It is yet not marketed. So the trials and all are complete, but marketing is yet to happen. So last year they said it will be available by end of December or probably in January. But now we are hearing that it has been delayed to May or June this year. So sometime soon we'll be getting it.
Thank you for the response, ma'am. There is one more query from Tina Thomas. Those who are sexually inactive, what test can they go for? Because doctor usually done pap test for inactive people.
No, we don't recommend any screening test for people who are who have yet never been exposed to sexual encounter, right? Because we are doing a per speculum examination, and we are not allowed to do a per speculum examination on a virgin lady, right? So none of the tests will happen. For such females, vaccination is a better strategy.
Then other query from Nisha Rato. When healthcare workers should take HPV vaccine or any people at which age?
So 9 to 14 years is the ideal age criteria. However, HPV vaccine can be given from 15 to 26 years of age, but we need to tell the patient, tell the person receiving the vaccine that it won't be as efficacious as it is mentioned. And however, I would like to make a point here that HPV vaccine is being licensed to use till 45 years of age. So if you feel that vaccine would be beneficial in somebody at that age, you can give vaccine. However, if somebody is sexually active and you are giving them a vaccine, definitely there will be a reduced efficacy. And for that lady, screening would be a better strategy than vaccination.
Another question from Renu Shioran. Ma'am, if HPV transmit through vertical transmission, then at what age the signs and symptoms will be represented by the recipient?
Okay, so vertical transmission is not at all common. It's not a common thing to happen. And very rarely we have seen some children having respiratory, papillomatosis. So papillomas in the respiratory tract. So I am not sure at what age the signs and symptoms will appear. I'll have to check it and get back to you.
Next question from Vijaya Yogesh. How women can get vaccine who are not covering under national health programs? Are the vaccines are available in private organizations?
So sometimes the concerned NGOs, they are associated with the salesperson of these companies, this GlaxoSmithKline and the other one is Merck's. So through NGOs they can get that, and even I think they are available through the your pediatricians also can help you get that vaccine. And I think all these good pharmacies might also help you. Whosoever is associated with these companies can help you get these vaccines.
Thank you, ma'am. Then another question from Sheena Varghese. Is the vaccine giving lifetime immunity or should it be repeated?
So yes. So there have been certain studies and one long trial that has put their results from UK. It has shown that the vaccine efficacies can go to lifetime. However, till now, the time period that they have covered so far is, I guess, 20 years or something. So we are yet not sure if it is giving a lifetime immunity. However, the titers that we have seen, so it covers a significant amount of time and no booster doses are recommended. Even a single dose vaccine is recommended these days because we are having so much vaccine shortage. We are thinking on these lines. Maybe for low resource settings, we can switch over from a 3-dose, 2-dose schedule to a single dose so that more number of girls are benefited.
Next question from Ria and Janet. Is the vaccines are effective after 30 years of age?
Vaccines are effective. So everything lies to that same point. If you are never exposed to that strain of virus and you are getting that vaccine, it will provide you 100% efficacy for that particular strain. However, if you are exposed to some other strain, it might not provide you that much efficacy. And if, for suppose, you are already infected with HPV, then vaccine is doing nothing for you. So it's not a therapeutic vaccine, it's a preventive vaccine.
Next question. Is HPV vaccine is recommended for both the males and females?
Good question. HPV vaccine is recommended for both males and females. However, it is not yet available for male use in our country. Why it is recommended for males is, number one, it provides herd immunity to the females because males will be the partners for females, right? If we are reducing the HPV infection in males, we are also reducing it in females. Second, it not only prevents us from cervical cancer, it also prevents us from so many other male cancers, the penile cancer, anal cancer, and even non-cancerous conditions like anal and penile warts.
Next question from Hemalada. Whether the repeated fungal infections can lead to cervical cancer?
Yes, any kind of repeated sexually transmitted infection, it is making you more vulnerable for that virus to stay back. If at all that infection happens, it will not go away, it will stay back. That is what repeated infections are doing.
Thank you, ma'am. Ma'am, we are getting many questions from participants. Whether we will continue it or not, ma'am.
That's up to you. If they are repeated questions, I think I've already answered most of them. If anything new is there, please let me know.
It's a repeated question, ma'am.
So that means it's already answered, right?
Ma'am, one more question. Is there any other risk for cervical cancer for earlier age?
I'm sorry, I didn't get you.
Is there any other risk for cervical cancer for earlier age?
Earlier age.
Yes, ma'am.
So for earlier age, the risk factors that we already discussed. So your sexual behavior, your lack of menstrual hygiene, lack of having early childbirth, multiple partners. So these are the risk factors. And yes, less immunity. So even females who are anemic, drastically anemic, anemia reduces your infection fighting capacity. So that again makes you more prone to getting such infection related cancers.
Thank you for responses, ma'am. No more questions, ma'am.
Thank you. So shall we call it a day?
So all participants kindly note, the webinar feedback form link is shared in the chat box. Please fill up the form for getting the e-certificate. Well, We have finished ahead of schedule for once. Now, let me invite Mrs. Grishma G. Nathan, Department of Obstetrics and Gynecological Nursing, Sree Anjaneya College of Nursing, for vote of thanks. Over to you, ma'am.
A warm and graceful good afternoon to our honorable dignitaries, distinguished guest and resource speaker, Dr. Pallavi Shukla, MD, PhD, and preventive oncologist, AIMS, New Delhi, and organizing chairperson of this webinar and principal of Sree Anjaneya College of Nursing, Dr. Professor Jorli Josh, and dignitaries attended the webinar and other participants. It's my privilege to propose a vote of thanks and acknowledge the contributions of those who really worked hard to make this event possible. I, Grishma Ji Nathan, on behalf of Sree Anjaneya College of Nursing and the entire fraternity of the institution, extend my sincere thanks to the Almighty for making today's event a grand success. I extend a hearty vote of thanks to our guest and resource speaker, Dr. Pallavi Shukla, who spared time from her busy schedule to grace this occasion. Today, we had an opportunity to hear your words and thoughts, and this will surely encourage us in all our future endeavors. Your deep and intellectual way of imparting knowledge has added to the glory of this event. Your thoughts have enlightened our mind and have shown us a new path. Today, we have got a lot of information which will truly help us in our life. We have no words to offer gratitude for your valuable presence here. You gave deep insight into the topic and revealed some interesting facts. Thank you, madam. Our sincere gratitude goes out to the chairman, Mr. Anil Kumar B., and other members of the management of Sree Anjaneya Medical Trust and IT Department of Malabar Medical College for their rock-solid support system and encouragement throughout. I would take this opportunity to express my deep regards to our principal and webinar organizing chairperson, Dr. Professor Jorli George, for being a constant motivator and guiding force in all our endeavors to excel in the field of education. Thank you, madam. I also want to thank Mr. Matthew Varghese V., Nursing Officer, AIMS, New Delhi, for his unfaltering support and his active participation in our event. An event like this cannot happen overnight. The wheels started rolling. It requires planning and bird's eye for detail. We have been fortunate enough to be backed by a team of a very proactive and dedicated staff. My deep sense of thanks and appreciation goes to all the participants who were live with us and attended the webinar with general enthusiasm, made today's event a grand success. Thank you all for being with us today. Have a wonderful day ahead. Over to Ashwini.
Let's wind up today's national webinar on cervical cancer. We will send you the e-certificate very soon. Thank you, Dr. Pallavi Shukla and all other participants of today's webinar. Have a nice day.
Thank you. Thank you.
மேம் எனக்கு மைக்க எப்படி food bag link, please. Ma'am, can you send the feedback form, please? Link, please.